Hello friends, today we're going to discuss about Delusional Misidentification Syndrome. I'm Dr. Suresh Badadmat, Professor of Psychiatry, working at National Institute of Mental Health and Neurosciences, Bangalore. In this video, I'll be discussing about Delusional Misidentification Syndrome, what are the different categories, how to diagnose, treatment will be discussed in this video. Delusional Misidentification Syndrome. It is a rare psychiatric disorder characterized by a group of delusional belief in which the individuals, like the patients, misidentifies the people, places, objects, or even themselves. These misidentification often involve a conviction that a person or animal or things or environment around them has changed in an unusual way, leading to various subtypes and various syndromes, my dear friends. Patient with delusional misidentification syndrome invariably become violent if they are untreated. The hostility is manifested against the so-called imposters if the patient believes, and it ranges from verbal aggression to physical aggression, at times homicidal ideas and threats, and even killing the impostor. At times, patient absconds from home because they believe imposters are staying at home. They believe the parents who are there, they are not their real parents. They are imposters. Hence, they refuse to come home. And they become wandering, mentally ill at large. The prevalence of this delusional misidentification syndrome in psychiatric population is less than 1%. But in inpatient population, it is 3%. And if you look at the patients who are psychotic, the percentage becomes 4%. Although it is a rare syndrome, but in psychotic patients, it becomes 4%, and for family members, it becomes miserable. That means they suffer a lot. In a recent prospective study of patients hospitalized for first psychotic episode, the delusional misidentification, that is Capgras syndrome, was diagnosed in 14%, my dear friends. That is, out of 517 patients, 73 reported of Capgras syndrome. The prevalence was maximal in schizophreniform patients, that is 50%, and brief psychotic disorder patient, 35% reported having delusional misidentification syndrome. Further, this syndrome is also seen in neurological condition or in organic insult, and they are commonly seen in neurodegenerative disorders. The prevalence of Capgras syndrome is reported 25% in patients suffering from Lewy body dementia and 10% in Alzheimer's type of dementia. Further, focal neurological injuries involving right frontotemporal region is classically involved having Capgras syndrome, my dear friends. Further, there are main 4 variants of delusional misidentification syndrome. The first one is Capgras syndrome. It is also called as delusion of doubles. Second one is subjective doubles, called as clonal pluralization, Fregoli syndrome, and Intermetamorphosis. Let's discuss each one of them. The etiology of delusional misidentification. Neuropsychological hypothesis based on cerebral dysfunctions are now commonly considered to be the origin of this disorder. They have been elaborated that in neurosciences, particularly, there is deficit in facial recognition models. Further, they've also clearly said that there is no problem in memory. There is no memory disorder. The person is able to recognize the people around him. Is able to recall those people who are stored in his memory. But the patient's experience may be envisaged as something is missing or something is absent from the experience. That is familiarity, or the feeling of missing something, or the feeling of unfamiliarity provokes the development of this delusional misidentification syndrome. There is one more hypothesis which has been proposed, that is dual lane model for Capgras syndrome. Here, delusional misidentification patient showed reduced autonomic responses on seeing familiar faces. This dissociation between the person identification and declined emotional response called this as a dual lane model. What is this dual lane model? One lane involves the limbic system attributed to the affective response. The second lane involves the ventral visual structures, enables recognition, and leads to the semantic and biographical information related to person and the name. And if there is a dissociation between these two, then there is a possibility of Capgras syndrome. And this is clearly explained by this photograph. In the first one, Capgras syndrome, patient sees familiar person, that is his family members, father and mother, but he identifies them as a persecutor and the impostors. That is delusion of doubles. Here the patient says, although they look like my parents, but they are not parents. They are impostors. They are disguised like my parents. Now coming to Fregoli syndrome. Here, the patient sees familiar persons in the surrounding, maybe sometimes unfamiliar person, and he says, the persecutors are coming in these people's faces, and he is able to recognize them. Moving to metamorphosis, also called as intermetamorphosis. Here the patient says that the familiar person who is standing in front of him changes his faces to various persecutors, and he is able to recognize each person. For example, the patient says he is seeing his doctor, and the doctor face changes to a persecutor, from one persecutor to another person, and third person also. That means he can see the face changing from one person to another person. The last one, subjective double syndrome. Here the patient sees himself in the mirror and believes that the impostor has taken over him, and he does not believe himself. Let's discuss about Capgras syndrome or Capgras delusion. It was first described by Jean-Joseph Capgras and his colleague Jean Riboll-Lecoq in 1923. In Capgras syndrome, an individual or the patient believes that a close family members or a family member, maybe father and mother, has been replaced by an identical impostor who looks and acts similar to his family member, but they are not his family members. Here the patient expresses distress, becomes confused, he cannot trust anyone. At the same time, he believes this delusion, and many a time they become violent towards the family members. For example, a 28-year-old male patient reported that his parents visiting him in the hospital are not real. They are imposters. They are identical to his parents, but they are persecutors. He knew because their behavior, their mannerism, and minor facial expressions were different than his family members. He believed that they are planning to kill him. That is Capgras syndrome, my dear friends. To make a diagnosis of Capgras syndrome, the person is recognized positively that they look like they are family members. That means the patient affirms the resemblance of the double to the misidentified significant others. That means he recognizes they look like his parents. That means there is no memory problem. He does not give identity to the double. The person who is standing, he says they are persecutors, but there is no name for them, and there is no existence about them. The double is an impostor, pretending to be original, and they have replaced them. That is his clear explanation. Further, he does not know where the original has disappeared, and he is unable to say where they have been kept. That means there is complete silence about the original person who is missing in action. So in Capgras syndrome, my dear friends, the patient clearly says that they look identical to the familiar person, that is, family members, but they are different in behaving. Hence, it is also called as hypo-identification syndrome, my dear friends. Let's look at the subjective doubles or clonal pluralization. It is also called as clonal identity delusion or else autoscopic delusion. In fish psychopathology, it is mentioned as phantom mirror image, my dear friends. It was first described by Christo Dolol, my dear friends. In this subtype, the individual believes that they have identical doubles or clones who exist separately from themselves and may be engaged in various activities and often including malicious intent and conspiracies against them. Patient clearly says that he is admitted in the hospital, but there is a clone or a double who is existing in the society and maligning their name. One example is Mr. X, 42-year-old, believed that there was an identical double. There is a clone who is sleeping with his husband and he is trying to injure her children. Patient believes that there is a doppelganger or double of themselves carrying out independent action to harm him or her. Moving to Fregoli syndrome or delusion, my dear friends. Here, the patient believes that various people whom he meets are actually the same person in disguise. Usually, they are unfamiliar person. He is identified as a familiar person but in disguise. Here, physical attributes may be different, but the personality of the persecutor is the same. For example, Mr. Y, 32-year-old male, reported that since morning he had seen persecutor coming into ward disguising as a doctor, nurse, ward attender, family members, or other patients, my dear friends. Here the individual believes that different, that is unfamiliar people are being disguised by an impostor. Even if they look different, the patient is able to recognize the persecutor. Hence, it is called as hyper-identification syndrome. Here, the patient says, I'm able to recognize the persecutor, although they are coming in different disguises, such as doctors, nurses, and various other people. Here, the patient clearly says, they look different. They are coming in unfamiliar faces, but he is able to identify the persecutor because the way the impostors are behaving or the persecutor is behaving. Hence, it is considered as hyper-identification syndrome, my dear friends. Similarly, there is something called as reverse Fregoli syndrome. Here, it is also called as anti-Fregoli syndrome, where a person believes that multiple individuals in their life, such as family, friends, relatives, who are genuinely different and unrelated to each other are actually the same person in disguise. Mr. Patient believes that several people in his life, including his co-worker Miss Y, his neighbor Miss S, and other therapist Dr. K, are all actually the same person pretending to be different individuals. That means the persecutor is coming disguised in various people as my dear friends. They look different, but they are family members or familiar person. But the persecutor is coming in disguise in front of him. That means he is able to recognize them because of their behavior. Hence, it can be considered as hyper-identification syndrome, my dear friends. Let's discuss about intermetamorphosis. In intermetamorphosis, this is a term describes a specific type of delusion or a perceptual disturbances where individuals believe that people, objects, or themselves are constantly changing or transforming into other people or objects. For example, Mrs. X, 56-year-old female patient, reported that she saw her son getting altered in appearance too, similar to husband, and then later he became her brother and he started converting himself as a doctor and later to nurse. And finally, he looked like grandfather. That means the patient sees the single person and his appearance is changing. Now let's discuss about Cotard delusion, the belief that oneself is dead or does not exist, sometimes coupled with the belief that one is putrefying and his internal organs also putrefying. And this is commonly seen in severe depression with delusion, my dear friends, or with psychotic symptoms. Mirrored self misidentification. Here, the patient believes that one's reflection in the mirror is someone else, and he is unable to identify himself in the mirror reflection, my dear friends. Further, there is another fantastic phenomenon which is called as reduplicative paramnesia. The belief that a familiar person, place, object, or body parts has been duplicated. For example, person may believe that they are in fact not in the hospital to which they are admitted, but in an identical looking hospital in a different part of the country. Here, the patient says, although he is admitted in the hospital, but it is not the hospital. It is a impostor hospital, impostor doctor. A pseudo community exists around him. That is reduplicative paramnesia, my dear friends. Further, somatoparaphrenia, the delusion where one denies ownership of his own limb or entire one side of the body. It is often associated with organic conditions such as stroke, my dear friends. How to do assessment in delusional misidentification patients? The detailed evaluation, collate information from multiple sources, take the patient's narrative, document verbatim report how the patient explains it, look at the behaviors of the patient, how he behaved with the so-called imposters and with the family members, whether he is acting on this delusion, family history, past history, personal history and premorbid history has to be taken, MSc and cognitive function has to be done, and look into the insight about these delusions. General physical examination, investigations such as CT scan and MRI, urine drug screening has to be done, CSF to look into infective pathology, and also to rule out autoimmune disorders has to be done. You need to differentiate between functional and organic misidentification syndrome. In functional syndrome, invariably it is early onset and invariably it is insidious onset. Other psychotic symptoms are known. Premorbid personality tendencies can be collected from the family members. No associated physical signs. Focal neurological deficits are not seen. Associated other psychiatric symptoms, other delusions, hallucinations, and course of illness will be fluctuating. That is, improvement and worsening can be seen based upon the compliance to medication. Whereas in organic, late onset, sudden worsening, no similarities with premorbid functioning, associated neurological dysfunction, focal signs, presence of other physical disabilities, no associated psychiatric symptoms, course will be stepladder deterioration is well known. What is the treatment for delusion of doubles or delusion of misidentification? There are hardly few studies which are well conducted, prospective studies looked into the course and outcome, treatment responses, and also the phenomenology. However, one need to know whether it is organic in origin or functional in nature. If it is organic, try to treat the cause, or else you have to make sure there is no second insult to the brain, such as stroke. You need to control hypertension and diabetes. If it is functional, you need to consider giving antipsychotic medications such as risperidone, olanzapine, pimozide, clozapine, aripiprazole, haloperidol, paliperidone. But however, there is no head-to-head comparison of these drugs. Most of the studies are case studies, my dear friends. That means we need to do a well-conducted study to know the response of medication in delusion of misidentification syndrome. Further, various case studies have reported using ECTs successfully in treating delusion of doubles. We need to educate the family members so that the family members do not become overburdened and they may desert the patient. Hence, we need to engage the family members. We need to make sure there is a supervised medication. If the patient is refusing medication, we need to consider parenteral medications so that these illness comes under control. However, cognitive behavioral therapies can be considered if the patient is cooperative. To conclude, delusional misidentification syndrome is a very rare syndrome, my dear friends. For every person, recognition, identification, and the feeling of familiarity and the emotions connected with this person is essential for our existence. However, the dissociation between the feelings and recognizing that person is seen in delusional misidentification syndrome. Hence, this hypothesis is called as dual lane model, my dear friends. Delusional misidentification syndrome can be challenging for the treating team, and further, long-term support is required for family members to providing care for these patients. Course and outcome is based on the etiology. Organic conditions are very difficult to treat. Functional conditions are also difficult to treat, but the compliance for medication and family support can have a good outcome. But however, the research in this area is very few. There are many questions, but answers are very few. That means unanswered questions are many in this curious little syndrome called as Capgras, my dear friends. Thank you very much for giving your valuable time. Stay safe.